is a different presentation to the one that Professor presented before me. We're talking mainly about fractures and broken bones. The second paper that I'm going to present, it's a paper that we did earlier this year. We were looking at the outcomes of treatment of fracture, non and delayed union using a device called the combined magnetic field bone stimulator. It was conducted in the East Kent University, East Kent Hospitals University Trust in the southeast of England. As a background, the William Harvey Hospital is a district general hospital, which is in the southeast of England. It's in this little corner of the country. It's trauma center for the East Kent Hospital University Trust. The trust has two other major or big hospitals, which are the Kent and Canterbury Hospital, as well as the Queen Elizabeth Queen Mother Hospital. So if any of you have, it's one of the most devastating injuries that a person can have. And the reason why we as clinicians or as orthopedic doctors exist is to try and ensure that fracture healing occurs to give patients the best possible outcome and to improve their quality of life. So we are particularly interested in ensuring that the fracture heals, and we invest a lot of time in understanding the mechanisms of fracture healing. Fracture healing is an intricate and complex process. It can be broadly divided into direct and indirect bone healing, with direct bone healing occurring when there is absolute stability. So when someone gets a surgical procedure to fix their bone using either a compression plating, or leg screws, you give the patient or the bone absolute stability, and direct bone healing occurs. With indirect bone healing, there is what we call relative stability, and this is commonly achieved by putting patients in plaster or plaster casts, and sometimes even the use of intermedullary nails. It tends to give patients relative stability, and fracture healing occurs. So in terms of the indirect bone healing, it follows four stages of healing, which are initiated by the inflammatory stage, formation of soft colors, then hard colors, and the last stage is remodeling of bone, which can take many months to years for it to occur. So as a definition, the CDC defines fracture non-union as failure of a fracture to unite after a minimum of 9 months with no signs of healing in the preceding 3 months, which some authors, they are not too happy with this fracture, this definition, because different fractures heal at different rates. Different bones heal at different rates. People of different age groups heal at different rates. So some others suggest a definition which says that fracture non-union is said to have occurred if the treating doctor or clinician says it has occurred. So someone who's treating wrist fractures might say they expect the fractures to heal maybe in 6 months. So if it's gone beyond that, to them, that's fracture non-union. And the reason why it is important to us is because we know that around 5 to 10% of all fractures will go into non-union. And this, according to a study that was done in the NHS, the cost of treating non-union can range from 7,000 to 79,000 pounds per person to treat these injuries. And non-union has a negative impact on the patient's quality of life, physical and mental well-being. So how do we make a diagnosis of that the fracture is not united or is gone into non-union? The diagnosis can be made clinically. The patient will complain of pain despite many months of treatment. There will be movement across the fracture sites. When you palpate the skin, you can feel crepitus and movement across the fracture site. All these are clinical signs of non-union. Then we also rely on radiologic evidence, in particular X-rays and CT scans. And on X-rays, you can see the absence of callus, the absence of bridging cortical trabecular on X-rays, and all these point towards nonunion. So when it comes to electric and magnetic field bone stimulators, there's been a growing interest in these over the last 20, 30 years, mainly because they are cheaper. They're a cheaper form of managing nonunion. They're less invasive compared to surgical procedures. The way they work is not clearly understood. As the name says, they subject a healing bone or a bone that's not uniting to electrical and magnetic fields. And this has been shown to increase factors that stimulate bone healing, such as insulin growth factor 2, calcitonin, interleukin 2, and calmodulin. And this is thought to be the mechanism of action. And when these factors are stimulated, there is stimulation of bone healing. And the device that was used in this study costs around 1,400 pounds, and the patient will use this. This is the entire cost of the device, and the patient will use this until the fracture unites. Comparing it to the cost of surgery, the cost of hospital stay, the loss of income associated with nonunion, we thought this is a cheaper and a more effective method compared to surgery. These devices, they came with directions of use. The directions were saying they're supposed to be applied for a minimum of 30 minutes per day. They're battery powered, which means the patient can carry this anywhere, even if they're traveling. And they're designed to act on a body part that it is prescribed for. For example, devices for maybe wrist nonunion are different from, for example, tibia nonunion. And the interesting thing about this as well is that they can be used in the case of patients who have had internal and external fixation, or even patients who are with a plaster of Paris cast on. They can still be used and be effective over these devices. Our study questions or objectives for our study were, number one, to assess the outcomes of treatment of delayed and established nonunion with combined magnetic field bone stimulators. We wanted to determine how long it takes after someone has been prescribed this device for them to achieve union. And we wanted to determine which fracture type tend to go into nonunion. So in terms of methodology, we did a retrospective review of patients treated with these bone stimulators. Our study period was quite long. It was over 2.5 years, from May 2029 to December 2021. We included all patients who had established nonunion, and this diagnosis had already been made by their treating orthopedic consultants. And we looked at those who had been treated with the combined magnetic field bone stimulators. And these patients were drawn from all the 3 hospitals that I mentioned earlier in our NHS trust. And we included all orthopedic subspecialties from spine, hand, upper limb, lower limb, as well as foot and ankle. We excluded patients whose follow-up had been less than 6 months at the time we did the study analysis. These patients were followed up at regular 3-month intervals using in the outpatients clinic. And at the end of the treatment, the patients had 2 outcomes: either they were discharged or they offered other treatment modalities for the nonunions. Of note is that we did not, we only followed up patients who had CMF treatment commenced by their treating clinicians. So in other words, we did not look for patients and prescribe the treatment ourselves. We did not monitor the patient's compliance at home. We trusted that the patients were following the recommended prescribed way of using this device at home, and we did not alter any routine treatment pathway for the patients. In terms of our results, we included, we came up with 29 patients, of which 4 were excluded because their follow-up period was less than 6 months. And in other words, we ended up studying 25 patients. And of these 25, 52% were female and 48% were male, with an average age of 53.42 years, with a standard deviation of 17 years. These patients had been commenced on this treatment from 4 to 27 months, with a mean time of commencement of 11.56 months, from the time of either the injury or the time of the initial surgery. In terms of the fracture type that we saw that tended to go into nonunion, we found out that the majority of the patients who went into nonunion had tibial shaft fractures with the number of 21, as well as distal femoral fractures with the number of 17, followed by ankle fractures. So most of these injuries or the nonunions were occurring in the lower limb. In the upper limb, we had 10 patients who had humeral shaft, who had distal humerus fractures, and 7 who had humeral shaft fractures. From when you analyze our results, we noted that 84% of our patients achieved union following this treatment, with the mean time of union being around 6 months. The majority, if you look at the graph on the right, the majority achieved union between 3 to 6 months from the time of commencement of treatment, which we thought was commendable, and it was a good time period to achieve union. 4 of our patients, unfortunately, failed treatment and were offered subsequent treatment. The first patient had a mid-shaft clavicle fracture, which had been initially treated with surgical fixation. This patient had been followed up for 6 months on this treatment, and unfortunately, the fracture had not united, so he went for repeat surgery and bone grafting, and afterwards, the fracture united. Patient B had a distal femur fracture, which had been initially treated surgically as well. It had been followed up for 6 months, and when we noted that the fracture was not uniting, he was then offered surgery with bone grafting. The third patient had a tibial plateau fracture, which had been treated conservatively and followed up for 11 months. And because it was not uniting, this patient was offered a total knee replacement. The last patient had a Lisp fracture, which had been fused initially and had been followed up for 14 months with no signs of union. Then she was offered repeat surgery in the form of a debridement and revision of fusion. So in summary, our series showed an 84% success rate with the use of these bone stimulators. The average time to union was around 6 months, with most achieving union at the 3 to 6 month interval. And more lower limb fractures went into nonunion compared to upper limb. And this is in keeping with literature as well, as we found out that more lower limb fractures tend to go more into nonunion compared to upper limb fractures. Conclusions that we made from this study were that bone growth stimulators using the combined magnetic field devices are a viable treatment option for established fracture nonunion. They can result in improved outcomes as seen in this study. And the good thing about them is they avoid risks and costs associated with surgical options to treat nonunion. However, our sample size was relatively small, so more studies need to be done to establish the efficacy of these devices conclusively. These were our references.